always start out with a big rectangular box. And I like to, on one side, make the total lung capacity. Okay, that's made up of all the volumes. And then on the opposite side, I like to draw the different volumes. Okay, so at the top here, we have IRV. The next one, we have tidal volume. Then we have expiratory reserve volume, and we have residual volume. Okay, so residual, and then let's draw one more. Okay, so there's 4 columns. So residual volume continues on. So residual volume is its own volume by itself. And then all 3 of these volumes make up vital capacity. Okay. And all 3 of these, and the vital capacity, can be measured on spirometry. Okay, now we have one more column here. So what's left is inspiratory portion. So IRV and tidal volume make up our inspiratory capacity. And then expiratory reserve and residual volume make up our functional residual capacity. Okay, so just drawing that multiple times will really kind of help you all understand it. So I did publish the answers, but let's go ahead and do a couple together so you kind of get the idea. So let's go ahead and start on number 3 on your homework. So first of all, I am going to write in with blue what's given. Okay, so I'm just going to copy here from the paper. What's given is a TLC of 6. Or let's use green. I'll use green. Let me try red. Well, that's weird. Sorry. We're using black. I don't know what happened to the other colors. Okay, so 6,000 mils is what's given for our total lung capacity. Our vital capacity is 4,700 mils. Our IRV is 3,000 milliliters. And then finally, our functional residual capacity is 2,400. Okay, so now we're asked to find the rest. Okay, so we're asked to find inspiratory capacity, residual volume, ERV, and tidal volume. So one of the things you need to do is just look at the board and say, okay, which one can I subtract from each other to fill out the rest of this? So as I'm looking at this, I see that my total lung capacity is given and my vital capacity is given. So if I subtract total lung capacity minus my vital capacity, I can get my residual volume. So if I subtract 6,000 milliliters from 4,700 milliliters, my answer then for my residual volume is 1,300 milliliters. Okay, do you all see how I did that? So you can kind of test yourself by saying, okay, let's see, 4,700 plus 1,300. Yes, that's 6,000, and that's my total lung capacity. So great, I already have solved 2 of the needed volumes. So then I say, let's see, I still see that I need to find ERV. Well, ERV, let's see. FRC minus RV. So if I say 2,400 minus 1,300, what's left is my ERV, because ERV and RV equals FRC. So if I say 2,400 minus 1,300, I get my ERV of 1,100. Great. So the only thing I have left are inspiratory capacity and tidal volume. And I already see a couple of ways I can solve for that. Just looking at it over here, I think that if I subtracted my total lung capacity minus my functional residual capacity, I could find my inspiratory capacity. So I could do that, or another way I could do it is look at my vital capacity. And since I already have 2 volumes of the vital capacity, I could add those and then subtract that from vital capacity. So I could do either one, okay? So let's just start from here and then we'll go down to the rest. So if we look at inspiratory capacity, 6,000 minus 2,400 leaves us an inspiratory capacity of 3,600. Okay, good. Now, finally, the last thing we need to do is solve for tidal volume. So the way I'll do that is look at inspiratory capacity of 3,600 minus inspiratory reserve volume of 3,000, and what's left is 600. Okay. And if you think about that, this is going to be a normal looking patient because we know that the whole total lung capacity is 6,000 milliliters. And of that, our tidal volume is usually 10% of that. And so that makes sense. So the numbers make sense. We can say, wow, this is probably a normal patient, just looking at the numbers compared to the way they're supposed to work out. So this was number 3. So 1,100, 600, 1,300, and 3,600 for the unknown volumes and capacities. Okay, let's move on to number 5 because I don't want to use, I only want to use whole numbers. I don't want anything that like 4950. I don't want to use that. I just want to use whole numbers. Okay, so I'm going to go ahead and put the numbers and values in for this one. So when we're doing this, as I said, always put in the patterns here, and then just kind of use it and work it like a puzzle. Okay, so on number 5, we're given a vital capacity of 4,600. We're given a functional residual capacity of 2,400. We're given a tidal volume of 700 and a residual volume of 1,300. Okay, so let's start filling in. If 1,300 is over here, oh, look at that. We've already filled in a whole column. So now we're looking at our total lung capacity. So 4,600 plus 1,300, we already have our total lung capacity. Okay, so that gives us 5,900. So we know that's a good start. Okay, cool. Well, once again, to find that inspiratory capacity, we can already see right here that total lung capacity minus our functional residual capacity, and what's left is our inspiratory capacity. So let's find that. We have 3,500. Good. So now we're only left with 2 volumes. So there's a couple of ways we could do that, but let's just kind of look and say, okay, what would be the easiest math? So I think going over here to our inspiratory capacity and our functional residual capacity and subtracting the tidal volume and residual volume will be the easiest. So let's start out with our IRV. Inspiratory capacity of 3,500 minus a tidal volume of 700. And what's left then for our IRV is 2,800. Okay. Now, there's a couple of ways I could do this, but I'm just going to stick to my functional residual capacity minus my residual volume, and what's left is my ERV, and that is 1,100. Okay, so does anybody have any questions, or would anyone like for me to do a different one?
There's a test that can tell us how well diffusion is going in the lungs. It's got one of those acronym names that are really hard to remember. So it starts with a D for diffusion, and then L because it's in the lungs, and then CO standing for carbon monoxide. Let me write that out. Carbon monoxide, that's the gas we use to do this test. And you're right, it's the same scary gas that we're afraid of being in our homes because it can poison us. And we'll get to in just a second why we use this gas. I guess to get really technical, diffusion will be talking about moving from a high concentration to a low concentration. But for our purposes, let's think of it as a gas moving across a barrier from place A to place B. In this case, in the lungs, we have an alveolus, which is the end of the airway in the lungs. This is where gas exchange will take place. Now it's covered by this layer of blood vessels. And we care about how diffusion goes here because usually its job, this whole area, is to have one gas diffuse from the airspace into the blood and another one from the blood to the airspace. So of course this one is oxygen and this one going from blood into the lungs is carbon dioxide. And this test is able to answer the question of how well can the lungs move a gas into the bloodstream. So to do this test, we have our patient here. Let's call him Mr. D for diffusion. All right, Mr. D here, if we look at his airway, it's connected to his mouth. And it's also connected to his nose up here. So here, through his nostrils, theoretically, that could also go down the airway. So to isolate all the numbers and data we're getting, his nose is going to be plugged. So he can only breathe through his mouth. So we put a mouthpiece into his mouth, and I can't draw what the machine really looks like, but just to get the idea here, we have one reservoir there. He breathes in through here, and then when he blows it out, the air goes to another machine. Let's draw it like this. And in the first one where he's breathing from, it's full of carbon monoxide. The gas that we mentioned is part of the name of this test. So he takes a big breath as much as he can breathe in. So carbon monoxide goes down his pipes into his lungs and it fills his lungs. Now a certain amount gets absorbed here into the bloodstream. And then when he can't breathe in anymore, he holds it for a second, for just a split second, and then he blows it all out as much as he can go. Keep going until he has no air left. Now the computer is able to calculate two things for us. One is how much carbon monoxide he breathed in, and then how much he breathed back out. And we'll care about these two numbers because essentially how much he took in minus how much came back out equals however much went into his bloodstream. So that's the amount that was diffused across. If we come back and look at this drawing here, the carbon monoxide goes in here and it fills this airspace. A certain amount, if it crosses in the bloodstream, and then all that's still left in the airspace, when he breathed out, it comes out here. So there's nowhere else for the gas to go. So either went in the bloodstream or it came back out. Therefore, our equation here gives us an estimate of how much gas diffused across. The reason we use carbon monoxide instead of the two gases that usually are in the lungs, the oxygen and the carbon dioxide, is because of the hemoglobin. Hemoglobin is something in our blood. It's part of the red blood cells, and its job is usually to carry these gases in our blood. It can carry actually multiple gases. First, it can carry carbon dioxide, which for our purposes is a waste product. So the body makes carbon dioxide, hemoglobin takes it up, and then when it gets to the lungs, it exchanges the carbon dioxide for oxygen. So back here, when we talked about these two gases being one going in, one going out, the vehicle is hemoglobin carrying it. Now, a third gas it carries is, of course, carbon monoxide. This is not usually part of what we breathe in. We just so happen to know that hemoglobin not only carries carbon monoxide, but it actually has a huge preference for it. It plays favorites. This is like its favorite kid. So here's why we use it in this test, is because since it likes carbon monoxide so much, we're able to maximize diffusion. Diffusion. Because when the hemoglobin in the blood sees the carbon monoxide, it grabs all of it up and gives us that maximum value of how well the diffusion is happening. But the reason we're so afraid of having carbon monoxide at home is, if you can imagine, if your air at home, there's a leak and there's carbon monoxide in the air. Many molecules of that. And there's also regular oxygen that we usually want. So if your hemoglobin you're picking out of these gases to pick up, you're going to choose all the carbon monoxide because you just like it better. So instead of carrying oxygen, it's going to carry carbon monoxide like this. Now this is a problem because hemoglobin's job is to take the oxygen all over. It can take the carbon monoxide to the same places, but our body can't use carbon monoxide. It's useless to us. Now it's okay for Mr. D to breathe in one breath of this, but if you do this for a couple minutes and you're breathing carbon monoxide instead of oxygen, and this person's quickly, their oxygen level is going to drop. So they're basically suffocating, even though they're still moving air in and out. And that's why carbon monoxide poisoning is so serious. So coming back to talk about diffusion, what on earth exactly are we testing for in the lungs? So what, it can diffuse well, but what does it mean if it does or does not diffuse well? So let's look at an equation of how gas behaves and what are the things that affect diffusion. So the volume of gas that can move across a barrier is equal to the area, surface area it's going across, divided by thickness of the membrane, or I'm sorry, the barrier, multiplied to a constant. This constant it's experimentally found is related to the gas, so we're not going to worry too much about that. But it's also related to the partial pressure of the first place minus the partial pressure of the second place with respect to whatever gas. Okay, let's tackle this one thing at a time. This first glob here, the area over thickness, that's really talking about the nature of the septum, the nature of the barrier that we have to move across. So in our case, assuming the blood vessels are okay, we're really looking at the membrane of the alveolus here. So the tissue of the lungs, what is the condition of that? For the gas to go through here, what is the surface area? What is the thickness? Now remember, for fractions, whatever's in the top of the fraction, if area goes up, then volume goes up. But if thickness goes up, volume goes down. So let's say something that can affect the surface area would be a disease such as emphysema, where the lung tissue is being destroyed and you literally get less surface area for diffusion. So in emphysema, the area goes down. And the area goes down, the volume is going to go down too because this is at the top of the equation. So another example, something that might affect the thickness would be, let's say fibrosis, where the lung tissue gets scarred and thickened, there's too much connective tissue. The thickness would go up. And because that's at the bottom of the equation, that actually drives the volume down too. So do you see how both these diseases would drive down the amount of the gas that goes across? And that's how they both impair the lung function. Now for partial pressures, I find the concept a little confusing. Let's try to look at it this way. So say there's a barrier, and you're a certain gas, and you want to go from area 1 to area 2. Now how willing this gas is to make its way over here depends on how much of it is on either side of this barrier. Say in the first scenario, if there's a ton of particles in the first area, and only 1 or 2 here, let's say 4 particles there, that's going to have a huge drive to push it over this way because the partial pressure of P1 is really high and the P2 is really low. So this absolute difference between the two is a driving force. In the other case, if we have about this much P1 here and then P2 is about the same, then this drive is going to be very small. There's not that much force pushing it over. So that's the same concept here, P1 minus P2. It's asking what's the difference in the gas in the airspace versus in the blood. So really the question is how much gas did we get into the area? How much gas was Mr. D able to breathe into his alveolus? I mean, P2 here should be about 0. There should be no carbon monoxide in your blood. So if you breathe a lot of it in, then the P1 minus P2 will be large. The more of a difference between P1 and P2, the higher the volume for diffusion. So the diseases that affect this part of the equation are the diseases that make it hard for air to get into the lungs. Let's say chronic bronchitis. There's all this mucus and blockage, so the air can't get into the alveolus. The lack of that air pressure in the airways, that's going to have a lower P1 minus P2. Actually, also with fibrosis and also with emphysema, they're also bad for the partial pressure difference because it's hard to get air in. So as you can see, for this test for diffusion, many different diseases in many different mechanisms can affect the diffusion. So this is not really a diagnostic test as much as it tells us how severe somebody's disease is.
Great. Okay. So that was a really good video for just kind of understanding diffusion capacity a little bit more. So now I am going to do another spirometry demo for you all. So I have my spirometer here. I have my mouthpiece called the spirette. Good. Okay. So this is my software that I'm going to be using, and I can do a multitude of tests. So I'm going to first find a patient. I'm going to find myself. Okay. So these are the tests I've already performed. Here is an example if I wanted to do different things. So forced vital capacity, exhalation only, that's what this is. Flow volume loop, so that's doing the whole exhalation and inhalation. Slow vital capacity, so that's if I just take a lot longer and I don't force that out. People with air trapping will do a little bit better on the slow vital capacity. Provocation is where I have the patient breathe in something like methacholine or mannitol, or have them do a trial of exercise and see if one can induce bronchospasm with these patients. MVV stands for maximum voluntary ventilation. And if you remind me, I'll do one of these for you guys. It's kind of hard, but it's looking at muscle strength and seeing how fast and how hard one can breathe in a minute. So I'm going to go ahead and do what we've been focusing on, and that's the flow volume loop from the forced vital capacity. Now, it's really important that I enter in this data because this is going to affect my tidal volume. So I'm going to add in here my ambient temperature. I'm going to add in here my humidity value and my altitude. And then based on that, my software here will convert my lung volumes from ambient temperature pressure dry to BTPS, body temperature pressure saturated. Okay, so I have different incentives here. So when I do my test, I'm going to try and blow out these birthday candles. Okay, and now that I already have my demographic data in for myself, my predicted values are already going to be given. Okay, so first thing I'm going to do is I'm going to put the spirometer in my mouth and just do some tidal breathing. Oh, it timed out. Okay, sorry. Let's try it again. Okay, here we go. Whew, okay. Okay, so here we go. And from that, we'll go ahead and look at my results. Okay, so it put up my results here. Okay, so here's my flow volume loop. I'm going to go over to my report just because it's a little bit easier to see on this way. Okay, so you guys now can see my report. Okay, so here is, I'm going to zoom in a little bit so you guys can see it a little bit easier. There we go. Okay, so first of all, we put in, and it's extremely important to put in all of my demographic data, such as my height, my gender, my ethnicity. Weight isn't that important. My date of birth is a big deal because it's going to fix my predicted values based on what I did. So for this test, it says, and we're really going to pay attention to these first three numbers, okay? The rest of them have a little bit of clinical effectiveness, but really for
more looking at these three first numbers will tell us if your patient is normal, showing an obstructive pattern or a restrictive pattern. So based on my demographic information, I should be able to get 3.67 liters out forcefully in 6 seconds, okay? And so my lower limit of normal is 2.98. I was able to get 4.11 liters out. So if you say and then it's the best. So if you do multiple trials, it'll always take the best value. So I was able to get 4.11 liters, and if you go 4.11 over 3.67, you get 112% of predicted. The forced vital capacity, normal is considered greater than 80% of predicted. Okay, so then we come down to our forced expiratory volume in 1 second. So if we go down here, that's represented by this. So this is the first 1 second. And then over here by this value as well. Okay, so this is the first 1 second of the whole flow volume loop as well. So with good muscle strength and patent airways and, you know, with just a lack of dynamic airflow obstruction, one should be able to easily blow out 83% of their whole volume in the first 1 second of their breath. So I should be able, of the 3.67 liters, I should have been able to get out 2.98 liters in that first 1 second. Well, I was able to. I was able to get out 3.36. So 3.36 divided by 2.98 is 113% of predicted. This normal value is also greater than 80%. The next value that we're going to look at that has a lot of clinical significance, very important to distinguish, is looking at the FEV1 over FVC ratio. Another term for that is the FEV1 ratio. So when we look at that, one should be able to get out about 82%. Lower limit of normal would be 72. Well, I was able to get out exactly about 82%. So looking at my best over my predicted, I got 100% of predicted. So looking at that, and then also looking at my flow volume loop. So what were we looking at? These were my first 2 tidal breaths. And then on my third breath, I took a really big inhalation in and I blasted all of that air out. And then I did another inhalation. And that's what it was looking at. So this flow volume loop is graphing flow against volume. That's why it's called a flow volume loop. So there's 2 variables graphed against each other. This here is called a volume time scalar. So here on the vertical y-axis is just volume in liters. And down here on the x horizontal axis is just time in seconds. So this one just graphs. So I did inhalation and exhale, and it just charted along my volume. So once again, you can see this steep portion of the curve, and that shows that that steep portion is me just really emptying those airways out, the larger airways. Then it takes a while to get all of the air out of that tracheobronchial tree. And you'll notice here, I couldn't get a lot more, okay, because I blasted it out. So this is a real plateau. So I was continuing to exhale, but you don't see a big increase in volume. So this is normal, and this is lower limit of normal. So I was right there in the zone where I should have been. Okay, so once again, we're looking at FVC should be greater than 80%, FEV1 should be greater than 80%, and then that ratio, according to the NBRC from ATS standards, this ratio should be greater than 70%. So if either one of these values is low and this number is also lower than 70%, that indicates that the patient has an obstructive pattern in their lungs. if the patient has one of these two values being low, but yet the FEV1 over FVC is greater than 70%, that means that the patient has a restrictive pattern in their lungs. Okay. Any questions? Okay, good. So finally, we're going to look at about 12 case studies. Okay. So good abbreviations to understand before going into this: FVC, forced vital capacity; FEV1, forced expiratory volume in 1 second; TLC, total lung capacity; residual volume, diffusion capacity for carbon monoxide; and BD stands for a bronchodilator, which this test is done quite often to see if a patient will respond to a bronchodilator. So you would see an increase in their FVC and FEV1 if they did. Okay, so we're just going to go through these. Case 1, we have a 65-year-old man who undergoes pulmonary function testing as part of a routine health screening test. He had no pulmonary complaints. He is a lifelong non-smoker and had a prior history of asbestos exposure while serving in the Navy. His pulmonary function tests are as follows. Okay, so here in all of them are the predicted values, and here are the actual values. So to get this percent of predicted, we're going to go actual over predicted. Okay, so this patient was able for the forced vital capacity to get 102% of predicted. For his FEV1, 95. So both of those are within normal limits. So therefore his ratio is 73%. So normal, normal, and 73. So this was just above normal. Okay, so that is a normal test, but this is on the low limit of normal, so he's getting close to an obstruction. Now let's go down and look at his lung volumes and capacities. So his total lung capacity is okay, it's 103% of predicted, and his residual volume is 109% of predicted. Now remember, when the residual volume is increased above where it's supposed to be, that usually indicates air trapping. And as we increase our residual volume, we will also increase our total lung capacity. So remember, with obstructive disorders, our volumes become larger, and with restrictive disorders, our volumes become smaller. Okay, so here's the flow volume loop. Not too bad, but based on that, we can look and see, and this case demonstrates an example of a normal pulmonary function test. The FVC and FEV1 are 100% and 92% of predicted. And the low limit of normal is greater than the predicted value, -8. So the flow volume loop also corresponds quite nicely to the predicted values for this patient. Based on this normal spirometry pattern, you could conclude that there is no evidence of airflow obstruction. This patient has normal total lung capacity, indicate there's no evidence of restriction, and a normal diffusion capacity for carbon monoxide indicated that the alveolar capillary surface area for gas exchange is normal. There's no bronchodilator response. So he's in pretty good shape. So that's good. Next, we have a 54-year-old man that presents to his primary care provider with dyspnea and a cough. He is a non-smoker with no relevant occupational exposure. So what we have here are just spirometry exams. So looking at the forced vital capacity, he is 76% of predicted. Looking at his FEV1, he's 64% predicted. So low, low, and then his actual ratio is only 68%. Low, low, and low shows he has an obstructive lung pattern. Then when you go down and look at his flow volume loop, this is predicted. Okay, this is before and after his bronchodilator. So you'll see that he was significantly obstructed here. Okay. Now, he did post-bronchodilator. So after he was given a short-acting beta agonist drug, bronchodilator, such as albuterol, his change was 25% for the FVC, 30% for the FEV1. According to the NBRC standards, there has to be a 12% change in order for us to say that, that the bronchodilator was effective. So to summarize, this guy showed an obstructive pattern that was reversed by a bronchodilator. Okay, so that's what they just talked about here. Okay, let's look at number 3. We have a 60-year-old man presents to his primary care provider with complaints of increasing dyspnea on exertion. He has a 40-pack-year history of smoking and is retired following a career as a building contractor. His PFT is as follows. Okay, so he has 41% of predicted FVC, 25%, and 47%. So he is significantly decreased in both FVC, FEV1, and his ratio. Okay, so then the percent change after, so he went from 41 to 96, from 25 to 112, which is a significant response. Then let's go down and look at his residual volume. So his residual volume, which as we said, indicates air trapping, is 248% of predicted. So that is extremely high. His total lung capacity then is 117%, so greater than normal. And then if you look, the residual volume over total lung capacity in a perfectly healthy young person would only be about 20% of predicted. So think about this. Of his total lung capacity, 76% of that is residual volume. Okay, now let's go and look at his DLCO, his diffusion capacity of carbon monoxide. So he was supposed to get 33, he only got 20.73. Therefore, his percent of predicted is only 62%. So for DLCO, greater than 80 is considered normal. So this person has quite significant obstructive disorder with an impaired diffusion capacity. Okay, and here's his flow volume loop. It says markedly abnormal spirometry. Oops, sorry about that. So he has severe airflow obstruction. He does meet the criteria for reversible from his post-bronchodilator. In addition, he has a lot of air trapping. And then finally, he does have poor perfusion or poor diffusion as well. Okay, let's look at case 4. We have a 25-year-old man presents to the physician with complaints of dyspnea and wheezing. He is a non-smoker. 2 years ago, he was in a major motor vehicle accident and was hospitalized for 3 months. He had a tracheostomy placed because he remained on the ventilator for a total of 7 weeks. His tracheostomy was removed 2 months after his discharge from the hospital. His PFTs are as shown, 109, 69, and only 54%. Okay, so that indicates an obstructive pattern because at least one of these values is lower than 80%, and this is lower than 70%. Now, if you look at this, you could say, oh, wow, so he is obstructive, but look at this flattened inspiratory and expiratory side. So this person really has a hard time getting air in and getting air out, okay? So this person has what you call a fixed obstruction. And from his history, it was shown that he had, or that he was previously trached. And so when people have long-term artificial airways, they a lot of time can get something called tracheal stenosis, where there's hardening of the trachea. And so that will cause this fixed airway obstruction. Okay, and so the flow volume loop would look something like this. So, you know, that's just a good indicator that, you know, the values can give you a pattern, but with patients' history, it can make a lot more sense for diagnosing what the pattern really is, or what the diagnosis is. Okay, so here we have a 41-year-old woman presents to the General Internal Medical Clinic at Harborview Medical Center complaining of dyspnea with mild exertion. She has a 10-pack-year history of smoking and a history of using intravenous drugs, including heroin and Ritalin. Her PFTs are as followed. Okay, so she had 29% of predicted for FVC, 19% for FEV1, and 54% for the ratio. So that is severely obstructive. Then if you go down and look at her volumes, yep, same pattern, increased residual volume, increased total lung capacity, and 80% of her whole total lung capacity is residual volume. Then you come down here to her diffusion capacity, and she's supposed to get 24.85, and she only got 0.75. So she's only 3% of predicted. Here is her flow volume loop. Okay, so she is classified as very severe obstructive lung disease. And her DLCO is also decreased, indicating a loss of alveolar capillary surface area for gas exchange. So it's pretty unlikely to have her, have something like this, but with her history, she really had some, she had some problems. Okay, so she's got like an emphysema pattern at 41 years old. Case 6, a 30-year-old woman presents for evaluation of dyspnea on exertion, which has been present for 2 months. She is a lifelong non-smoker with no prior history of asthma or other pulmonary problems. She works as a receptionist at a publishing company. She has 2 cats and several parakeets at home. Her pulmonary function testing is as follows. Okay, so pre-bronchodilator, and as you can see, there's no change. 40% predicted, 43% of predicted, so both of these are severely limited. Then if you look at the ratio, it's 91%, so it's above that 70%. So if you have a low forced vital capacity and a low FEV1, and you have a normal ratio, that indicates a restrictive lung disease. Now, let's go over here and look at her lung volumes and capacities. Her residual volume is only 51%, and her total lung capacity is 44%. As we talked about before, in restrictive diseases, all lung volumes are diminished. So we have restriction with, once again, a very impaired diffusion capacity. Okay, so something in the alveolar capillary membrane is not letting that gas diffuse. And then if you look at her flow volume loop, you can see that it's narrowed or pinched. And so she's got something that's really restricting her lungs from expanding and getting that air in. Okay, so with her history, she has something that most likely could be categorized as an interstitial lung disease. Okay, so there's something going on in the lung parenchyma. Okay, so something that this patient has, and one of the things that you want to go ding, ding, ding right away is the patient had birds. So there's something with birds that a lot of people have this hypersensitivity pneumonitis. And so what it causes is it causes inflammation in the lung parenchyma itself. Okay, so she was given some steroids, and look, she did much better. So post-treatment, 69%, 66%, and 80%. So she did much better post-treatment. And then her diffusion capacity is much better. She's not cured, so we definitely want to say she's not cured, but she's really improving. So you guys can see these bilateral little opacities throughout both lungs. This is very common to a widespread interstitial type of lung disease, really something that's bothering the lung parenchyma. So in this case, it was inflammation. So this was pre-treatment and this was post-treatment to the steroids. Okay, so history, spirometry, and imaging together really gives you a good picture of what's going on with the patient. So here, case 7, we have a 73-year-old woman presents with progressive dyspnea on exertion over the past 1 year. He reports a dry cough, no wheezes, sputum, fevers, or hemoptysis. He is a lifelong non-smoker and worked as a lawyer until retiring 3 years ago. He likes to hunt and fish in his leisure time. His pulmonary function testing are as follows: 35%, 38%, and 82%. So with this significant decrease, we'll look at his flow volume loop, and you can see that pinched in, or that squeezed in appearance that would, along with the lung volumes and capacities being lower than predicted. And then finally, this gentleman has a impaired diffusion, okay, impaired diffusion capacity. So we have a restrictive pattern with low lung volumes and capacities and a decrease in our diffusion capacity, and that is most likely from an interstitial lung disease called pulmonary fibrosis. Okay, there would have to be other tests done, but yep, he does have pulmonary fibrosis looking at his imaging. And once again, you see all that scarring throughout both sides of the lung parenchyma. Okay. Case 8, we have a 64-year-old woman presents with complaints of dyspnea and orthopnea. She is a lifelong non-smoker. Her PFT is as shows: 40%, 30%, 61%. So when we have low, 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 that's a good indicator that the patient is obstructing in their airways. However, take a look at this. She also has low lung volumes and capacities. Okay, so this person, this is an example of a patient having both a restrictive and obstructive component in their lungs. And that does happen with patients. Now, when you think of orthopnea, that means that it's much easier to breathe in the upright position. So here they did her spirometry repeated, laying down and sitting up. And so there was a significant difference. And wow, look at that obstructive pattern, obstructive and restrictive. So in that case, there's most likely some sort of heart problem, or she has some sort of vascular disease. Okay, and so that would account for her lying down or sitting up. Now, really, when they do the test and they change positions from sitting up or lying down, that could actually indicate that this person has diaphragmatic weakness, and that's what that gravitational difference in volumes is related to. Okay, case 9, we have a 35-year-old previously healthy man that presents with dyspnea, fevers, chills, and night sweats for the past 2 months. Non-smoker, no concerning habits or occupational exposure. PFTs are as follows: 37%, 26%, and 57%. So this person has an obstructive component in their airways. However, we look down at the lung volumes and capacities, and that's also diminished. Okay, and let's look at the flow volume loop. Ooh, wow. So if we look at this flow volume loop, we can see this scooped out obstructive pattern, and look at this. Look at this volume. That is showing that it's also diminished. So this person also has both obstructive and restrictive pattern. Now, something in his history that was quite concerning was the night sweats. So night sweats generally happen with lung cancer and tuberculosis. So in this, with this pattern, we really would be concerned with some sort of cancer. And then we look at the imaging, and oh my goodness, he has an extremely large mass on this right side. And then we look at the imaging of the chest x-ray, and once again, oh my goodness, an extreme mass right here on that right side. So this person's not doing really well. Okay, case 10. 53-year-old woman presents with an increasing dyspnea on exertion. She denies cough, fever, hemoptysis, weight loss, or sweats. She was previously an active runner, but has had to cut back significantly because of her symptoms with exercise. She does note occasional chest pain with exercise, but has not only had any syncope or palpitations. Her PFTs are as follows. Okay, 83%, 84%, and 82%. And her volumes and capacities are also normal. So her spirometry and her lung volumes and capacities are normal. However, her DLCO, her diffusion capacity, is only 43% of predicted. So she's got a significant, even though her lungs, everything's look fine with her lungs, that diffusion capacity is not good. So with history and looking at that, that would generally indicate some sort of pulmonary vascular disease. And based of that, it was found that she had pulmonary hypertension due to chronic thromboembolic disease. So she has multiple blood clots in her pulmonary vascular system that's leading to pulmonary hypertension. 11, 36-year-old woman presents with a several-month history of worsening dyspnea on exertion and exercise limitation. Lifelong non-smoker, no history of asthma or unknown pulmonary disease. She's had to stop going out with her weekly running group because she can no longer keep up with her friends. Her PFT are as below. Okay, so she has 26% of predicted, 30% of predicted, and therefore 99% of predicted FEV1 percentage. Okay, so she has this indicates restriction. Then we look here, and yeah, her TLC is only, her lung is only 53% of predicted. So that is also indicative of restrictive component. Okay, so, and then she does have a normal DLCO. Okay, so there's some problem with the problem due to her disease. And it looks like she also had some problems, and so she is, it did some further testing. She had a 17% drop in her FVC from sitting to supine. Her maximum inspiratory pressures were only negative 35, an expiratory 35, and a peak cough flow 180 liters per minute, and those are all markedly reduced. And so this person has muscle weakness. So upon further evaluation by a neurologist, she was found to have muscular dystrophy. Okay, last case. We have a 44-year-old woman with cirrhosis secondary to chronic alcohol abuse and hepatitis C. She presents with complaints of increasing dyspnea. She reports that her dyspnea is worse when she is sitting upright or walking, but improves when she is lying flat, and that's called platypnea. She is an active cigarette smoker. On exam, she has a room air sat of 88 in the sitting position and a room air sat of 96% in the supine position. So that's opposite of what we usually think. So this is an example of platypnea. Her PFT are as follows: 107%, 91%, and 70%. Then you look at her volumes and capacities, and they're just fine, but she has a really reduced diffusion capacity. Okay, and so based on that, this person is shown to have a pulmonary vascular problem related to her hepatomegaly, or not, excuse me, her hepatomegaly syndrome and hepatopulmonary syndrome, which means there's blood flow restriction from the liver up to the lungs. Okay, so That is it. Okay, so I have one more thing that I want to show you guys, and then we'll open it up for questions. So one of the things I wanted to show you guys was the MVV, and that's the maximum voluntary ventilation test. Okay, so I'm going to go back to my software, and I'm going to return back to the main page. I want to go back to tests. And this test I don't like doing because it's kind of hard. Okay, I'm going to block this to do a... Okay, so with this test, this is my maximum voluntary ventilation. So here I go. Woo, that's hard. So what I just did is I took in all the volume, and so I went into my tidal volume and my respiratory rate as hard and fast as I could. And so I had to do that for 12 seconds. So based on that, what I was supposed to get was about 103.2, and that would be liters in every minute. So imagine, we probably do, what's our normal minute ventilation? Our normal minute ventilation is really about, if we think about it, 4 liters per minute. In this case, the maximum, you're supposed to get 100 liters per minute. That's really hard. And you can see I actually had to take a couple of breaths here. I felt like I was choking. So this test is really hard, and it's a really good indicator for patients with muscle weakness. Okay, so if they are really low in this, and that means that they do have muscle weakness and they may need to have additional augmentation of their ventilation. So they might need to go on non-invasive, they might need to be intubated, or they might just need to have further conditioning.